Okay, I am pleased to introduce my colleague, Dr. Britta Berg, today, who's going to be presenting to us on caring beyond cure, understanding palliative medicine. Dr. Berg is an assistant professor in the Department of Medicine in General Internal Medicine. She did her medical education at the University of Rostock and Freiburg in Germany. She have received a scholarship from the German National Merit Foundation that she completed at the Diabetes Institute for Immunology and Transplantation in Minneapolis and the Case Western Reserve University in Cleveland, Ohio, and earned a research doctorate degree. Before joining us at McMaster, Dr. Berg had completed her residency training in internal medicine, specializing in palliative medicine. She has practiced in tertiary care centers as well as in setting of community outreach in Germany. Dr. Berg's academic interests are in palliative medicine and residency education. She is currently the competency committee chair for the Royal College Palliative Care, Royal College Palliative Medicine Program, and a competency committee member of the Royal College Internal Medicine Program. Dr. Berg does her clinical work at both Hamilton Health Sciences and St. Joe's, and she's passionate about improving quality of life for patients with life-limiting illnesses. I'm really eager to listen to Dr. Berg's talk today. Palliative medicine is very close to my heart, and we're going to learn a lot. So without further ado, welcome Dr. Berg. Britta, please go ahead.
Thank you very much, Khalid, for the kind introduction. I would like to start my presentation with acknowledging that McMaster University, as well as all the hospitals here in Hamilton, recognize that they are located on the traditional territories of the Mississauga and Haudenosaunee nations and within the lands protected by the Dish with One Spoon Wampum Agreement. Tracy Anthony is the artist behind this beautiful picture that can be found at the Hamilton General Hospital, and many of us walk by several times a day. It is a gentle reminder that we are truly privileged to provide care on lands that Indigenous people have called their home for thousands of years. I have no conflicts of interest to declare. So I would like to give you an outline so you have an idea of what to expect over the next 45 minutes. We will start with some background information. I will try to shine a light on the rich history of a very young Royal College subspecialty. Afterwards, I will give you an idea of when to get palliative medicine involved and what we do, illustrated with a case. Last but not least, I want to focus on the palliative medicine landscape here in Hamilton and the resources, especially when it comes to discharge planning. So let's dive in. When you suggest to a patient that the palliative care team should get involved, quite often the patient or their family will not be happy. They perceive the suggestion as information that they are about to die and that there is nothing more to do. Palliative equals giving up equals dying. But where does this bad reputation come from? To my knowledge, there is no specialty or subspecialty that has more discussion about their name than ours. Some feel the word palliative scares away patients and rename their services to pain and symptom management service or supportive care. So where does the negative connotation come from? Probably there are two main reasons. First of all, palliative is used as an opposite to curative. Curative, coming from the Latin word curare, meaning to care or to treat, and is very close to the English word cure, we all means healing. So the opposite, palliative, means not to heal and eventually to die. The second reason for the bad reputation of the word is that it's historically that palliative medicine used to be end-of-life care. It was introduced when there were no more curative options, and it was strictly used end of life. But where does the word come from and what does the word actually mean? The word palliative also is of Latin origin. It's from the Latin word pallium, meaning cloak, long coat, or warm blanket. The corresponding verb palliare means to cover someone with a blanket. And why would you do that? You would do it to prevent someone from freezing or to protect them from rain or from the sun, all to make them feel more comfortable. Keeping this in mind, the word palliative, after all, seems very appropriate for our services, as providing comfort is our main goal. Even though palliative medicine is a very young subspecialty here in Canada, it has a rich history that has evolved over centuries. About 2,500 years ago, on the beautiful Greek island coast, Hippocrates, the father of medicine, practiced in what was history's first medical hospital. His goal already was to cure sometimes, treat often, and comfort always. Thanks to agents like antibiotics and modern technology, maybe we can achieve cure more often nowadays, but there are still enough patients who will never be cured and who will most definitely appreciate comfort. The concept of providing comfort and reducing suffering to patients with serious illnesses was recognized by other ancient civilizations like Egypt and Rome. During the Middle Ages, religious institutions played a lead role in caring for the dying. The first so-called hospices were found on key crossroads to shrines to care for people on pilgrimage who might have started their journey in hopes of cure, but succumbed to illness while being on the road. One example of what you may call an early pioneer of very early palliative care is St. Vincent de Paul. In 1633, Vincent was a young priest. He founded the Holy Order of Sister for Charity in Paris, and they opened more than 40 houses for poor, sick, and dying. Up until the 19th century, the belief in Europe and in the USA was that the family and church are in charge of dying and of supporting families in grief. The 20th century marks the start point for modern palliative care. A young woman in England was studying philosophy, politics, and economics before the outbreak of World War II. Her name is Cicely Saunders, and like many, the war changed her plans, and she ended up becoming a nurse and working as social worker in a hospital in London, England. It was there that she recognized that especially many cancer patients suffer from severe pain at their end of life. This inspired her to go back to college and become a doctor later on. She was studying pain control in advanced cancer patients and introduced the concept of opioids not only given PRN, but also by the clock. She's the founder of Christopher Street Hospice in Sydenham, south of London, that opened in 1967. It's deemed to be the first modern hospice. There were many hospices providing expert nursing care prior to the establishment of Christopher's Hospice. However, the latter one was revolutionary in uniting expert pain and symptom control, passionate care, teaching, and clinical research to treat a patient holistically. Cicely Saunders is the founder of modern hospice movement, and others call her the mother of palliative care. Google honored her with a Google Doodle. It would have been her 100th birthday. The doodle was accompanied by the following text. Born 100 years ago, Saunders performed many roles in her life, including nurse, doctor, author, and social worker. It was while caring for a terminally ill patient that she recognized certain challenges other medical professionals at her time did not, that this diagnosis required a fundamentally different kind of healthcare. So what was the difference in her approach, and what are the principles of modern palliative care? Maybe because of her background, being a nurse, social worker, and MD, she realized how beneficial a multidisciplinary approach to caring for dying can be. She advocated for careful attention to social, spiritual, and psychological suffering of patients and their families. I would like to read out a few famous quotes to you, since it does not only show who this remarkable human being was, but also illustrates the core beliefs and values of our subspecialty. You matter because you are, and you matter until the last moment of your life. And we will do all we can, not only to help you die peacefully, but also to live until you die. We need to help the dying to live until they die and their families to live on. No human life, no matter how wretched, should be denied dignity and love. Death must not be seen as a failure, but as part of our life. And how people die, and that's very important, remains in the memory of those to live on. Now let's zoom in and focus on palliative care in Canada. As much as Cicely Saunders is recognized as the mother of modern palliative care, North America has a father of palliative care. His name is Rolf Mount. He is a urologist from Montreal, and as a young physician, he heard about Cicely Saunders and her ideas and actions and all her work in what she called hospice care. He wanted to visit Christopher's hospice and reached out to Cicely Saunders with this request. She responded that she would welcome him, but only if he was willing to stay for a whole week and willing to work with the team during this time. So he agreed. He was hosted in September of 1973 for 1 week, and he was deeply impressed by his experience. While he realized there was a better way to provide end-of-life care, he also realized that for the 80% of Canadians who died in institutions, there would never be a sufficient number of hospices available to serve the population. So he made a proposal not just for a hospice, but for a whole program at the Royal Victoria Hospital in Montreal, and the board agreed to a 2-year pilot project starting in 1975. The services at this time consisted of a home care program, an inpatient ward, a consultation service to the active treatment programs, a bereavement follow-up team to follow patients judged at higher risk for bereavement problems, as well as research and teaching. So it was a comprehensive service, foundational to hospice care in Canada. Dr. Mount was approached by his Francophone colleagues who had determined that the term hospice should not be used since it had a bad connotation in France, suggesting a place of quite insufficient care. So he had to come up with a new name, which should be, as we know it now, palliative care. He ran the name by Cicely Saunders, who was not really convinced. He went with it anyways and was very pleased when a few years later, the Royal College of London and Edinburgh chose the term palliative medicine as its new specialty. Dr. Mount has not yet been honored with a Google Doodle. He didn't really qualify, as to my knowledge, he's still alive, but he can be found on a step. Now zooming in on Hamilton, we also do have our own pioneer in palliative care. Her name is Elizabeth Joan Latimer, or known by her friends and colleagues as Liz. Like Cicely Saunders, she was also a nurse as well as a doctor. She was fundamental in the development of palliative care here at McMaster. She loved to travel and loved to lecture around the world. She wrote many scholarly articles. But most importantly, colleagues who were lucky enough to have met her, who learned from her and who worked alongside her, describe her as kind, humble, and able to capture and embrace the moment. She was known for empathy, calmness, and for being non-judgmental. One colleague says she was able to slow down and really understand what a patient needed. Once a year, the Division of Palliative Medicine awards the Elizabeth J. Latimer Prize to honor Dr. Latimer, as well as the recipient, and to celebrate that her legacy does live on. The quote I love is, "Don't just do something, sit there." Next, I would like to have a look on the academic development of our discipline. The coining of the term palliative care in 1975 by Dr. Mount is seen as the start of our discipline here in Canada. In 1993, the Canadian Society of Palliative Care Physicians formed, and their goal was to establish palliative medicine as formalized academic and clinical discipline, recognized by both colleges, the College of Family Physicians and the Royal College. The first application was rejected in 1994. It was rejected, stating that care of dying was a general competence. The rejection did not prevent the College of Family Physicians and the Royal College to develop a formalized training in palliative medicine. In 1999, the Year of Added Competency was established, jointly sponsored and recognized by the CFPC and the Royal College. Over the next decade, the complexity of our patient population grew due to extending our services to not only help with end-of-life care, but to facilitate early integration of palliative care. In addition, we now also offer support to chronically ill patients with end-stage organ disease. voices became louder again to create a subspecialty or a specialty to gain recognition and to advance the field of palliative medicine in Canada. The Canadian Society of Palliative Care Physicians was hoping to continue with a joint program between the two colleges and build on the already existing year of added competency. But this could not be achieved for a variety of reasons. One being that the College of Family Physicians sees its role in training well-rounded generalists, and a 2-year program for specializing in palliative medicine would not be in keeping with their mission. So in 2010, the decision was made to develop a 2-year Royal College and a 1-year program for the College of Family Physicians in parallel. This is the reason why we now have 2 training programs for future palliative care physicians. Family Medicine calls their program an Enhanced Skills Program, and the Royal College is the Adult Palliative Medicine Subspecialty Program. It launched in Canada 6 years ago in 2017 and at McMaster in 2021. So what do you have to do if you want to enter the palliative medicine field? As you know, the subspecialty status initially was denied because palliative medicine is everyone's business, and that is still true. So everyone should be aware that it is indeed possible to treat an illness without treating a patient. So never lose sight of a patient, especially end of life. If you are interested to learn more about palliative medicine to improve your palliative care skills, there are great online resources. I have only named here 2 to give some examples. You can check the Pallium Canada website. It is free, or it has free modules for McMaster learners, and it can be accessed through the McMaster library. The other one, that's my favorite, is the Canadian Virtual Hospice. They offer lots of information and support on palliative end-of-life care, loss, and grief. If you are interested, for example, to look into how people experience end-of-life, depending on their culture, there's a whole section with short videos where people from different backgrounds have been interviewed and give their perspective on end-of-life and expectations for care and grief. As I pointed out earlier, if you are a family medicine resident or a family physician, you can apply to the Enhanced Skills Program. It's a 1-year program after your family medicine residency training, and you have to apply through CARMS. If you are considering becoming an adult palliative medicine subspecialist recognized by the Royal College, you will need to apply to the Royal College Palliative Care Program through CARMS. There's a direct entry pathway for all applicants with a background in internal medicine, neurology, and anesthesiology. But you can also apply from any other specialty, including palliative care, if you have completed at least 12 months of training in GIM based on clinical rotations with at least 6 months on a senior level. Now you know how palliative medicine came to be, so let's move on to the second part, when to get palliative care involved. Before putting in a consult request for palliative care, you should have done 3 steps. First, you have to identify your patient that would benefit from a palliative care approach. Next, you have to talk to them and explore their goals of care. And if you feel that in order to achieve their goals of care, you would need some help, then that's a good time to reach out. We are consulted for symptom management. It can be physical symptoms, pain, dyspnea, nausea, constipation, but sometimes it's more psychosocial symptoms, agitation, suffering. Sometimes it's even the suffering of the family that can prompt you to call us. We are consulted for complex conversational and family dynamics. I like to enforce the word complex here. As pointed out earlier, everyone should be able to have a basic goals of care discussion. But if, for example, you have a patient with malignant bowel obstruction, end of life, you would feel will never be able to return home, might benefit from inpatient palliative care in a hospice, and the family insists on full code, this might be a candidate to refer to us. Those conversations can take up plenty of time, and psychosocial support you might not be able to provide by being a busy service on the ward. We are also consulted for discharge planning, and same as previous, If a patient simply has a life-limiting illness, but no significant symptom burden and can return home or back to long-term care, palliative care does not need to be consulted. Most long-term care places are well-equipped and very experienced with providing end-of-life care. But we might be helpful in more complicated cases. All those categories would warrant their own presentation, or already had one earlier this year. Therefore, I will try to attend to each of them I will not try to attend to each of them in more detail today, but I would like to exemplify our work and involvement on a case that fits into the first two categories, and afterwards we'll talk about discharge planning and resources here in Hamilton. While I present to you this case, I would like you to reflect on your thoughts about patient needs, and maybe also on your level of empathy and how those things change when you get to know the patient better. I changed the name and a few details for confidentiality, but it's still one of my patients I'm talking about. You will meet Mary. Mary is a 64-year-old female presenting to ER with nausea, vomiting, and back pain. She has a past medical history of diabetes and an NSTEMI a year prior. Leading up to the presentation, she experienced a period of 6 to 9 months with increasing difficulty swallowing and has lost significant weight, 100 pounds overall, 50 in the past 2 months. An extensive workup was done as an outpatient, and she was diagnosed with achalasia. A peroral endoscopic myotomy attempt was done. Unfortunately, the mucosa looked suspicious and biopsies were taken. At this time, she presented to the ER, no oral intake at all, dehydrated and weak. A CT chest up to pelvis revealed an extensive metastatic illness, multiple bone mets, explaining her back pain. Most likely, the primary would be an adenocarcinoma of her lower esophagus, extensive tumor burden in mediastinum, infiltrating the lower esophagus wall, causing secondary achalasia. The MRP revealed the findings to the patient, and this was the first time the patient was confronted with actually a life-threatening condition. I'm just pointing this out because it's so important to know where a patient is in their illness understanding. As soon as we, as doctors or healthcare workers, realize, oh, it's metastatic cancer, that explains all the symptoms, you might already be one step ahead when you go into the conversation talking about next steps, treatments, options, and so on. The patient might not have had a chance to process the bad news. And even though you still need to talk about next steps and so on, being aware of where someone is in their illness understanding and processing might change how you approach the conversation. We were consulted for symptom management. We started the patient on opioids for pain. We started her on antiemetics, and we supported a referral to palliative radiation to help with pain management. But symptom management, even so very evident in this case, it brought her in, was not the only need this patient had. If we look into her family history, her mom passed away from gastric cancer at age 45. Why is this family history important? You could argue it might suggest a genetic disposition in regarding to a possible cancer diagnosis. You might find yourself digging in your brains and searching for cancers that have a genetic component, and this might be important later on when it comes to counseling the family on screening options. But more importantly, at this point in time, the patient has seen a very close family member, actually her mom, die from cancer. She has most likely witnessed her mom losing weight and was probably on high alarm over the past few months faced with her own weight loss. She probably was very relieved with all negative tests and being told achalasia explains her symptoms and can be treated. So now her worst fear came true. She might respond completely different to this diagnosis than someone who has never experienced a loved one die, or might even have friends who survived a cancer diagnosis. You need to know a patient and not only their illness in order to understand who a person is and in order to be able to identify their needs. So the social history is usually very important to us, and especially in this case. It reveals that this person has been a very successful salesperson at the height of her career. She was just awarded the Canadian Salesperson of the Month from her company the months prior to admission. Her husband passed away 6 months ago. She has 3 adult children, one currently treated for leukemia. She has 2 grandchildren, and Mary and her husband were caregivers for the 9-year-old granddaughter. She basically raised her as her youngest child, and even she told me she felt too young to be called grandma. So she was basically the mom for the granddaughter. So now that you know Mary a little bit better, what are Mary's needs? It's for sure symptom management. That was very important in this case. But it was also coping with an acute life-threatening illness, sorting out financial things, but foremost making sure the granddaughter will be okay. Luckily, palliative care is a multidisciplinary approach. We work close together with psychologists, social work, spiritual care, clinical nurse specialists, and physicians from all different specialties, in this case, surgery, GI, radiation oncology. But despite all efforts, the patient declined very fast. And at this point, the prognosis was more within days than weeks. Despite being on continuous infusion of opioids, the pain was not controlled well. She started to vomit blood, experiencing nosebleed, and felt miserable. She was suffering and couldn't tolerate it anymore. One morning, she called our service and stated she can't bear it anymore. She didn't want to end her life prematurely, but could not tolerate the suffering. At this point in time, we offered palliative sedation, and I want to take this opportunity to do a brief excursion on palliative sedation therapy, since we have received a few consults most recently indicating that there is some need for clarification. Palliative sedation is a sedation during the final days of life when suffering becomes intolerable due to refractory symptoms. It's a tool to enable a patient to pass peacefully at a time natural death would occur anyways. It is not meant to hasten death. Though there are clear criteria or indications for palliative sedation, the symptoms must be refractory and intolerable. Other symptom management options must have failed, and the prognosis is less than a week. If you offer palliative sedation, you need to be able to, first of all, you need to discuss with a substitute decision maker or the patient. And then you need to be able to provide close monitoring for the level of sedation, but also for the symptoms, because quiet does not equal comfort. For the level of sedation, we use the RASS scale. Most often we aim for a RASS of -4, but sometimes the patient is comfortable at a RASS of -1. For monitoring symptoms, there is a pain AD scale. It's used in advanced dementia to identify patients who have pain, and it relies on your observation skills. You should be in a patient room for about 5 minutes, observing the breathing pattern, the breathing overall, negative vocalization. You should watch for facial expression and for body language, because this can all give you an idea if a patient is comfortable or not. So in summary, palliative sedation is not intended to hasten death, but to make the patient and the patient's family more comfortable during the last days of a patient's life, if all other symptom management approaches fail. As Cecily Saunders already mentioned, how people die remains in the memory of those who do live on. So back to our case, we offered palliative sedation. The patient was very clear that this is what she wanted, and she was aware that she would most likely be asleep until death would occur naturally. In this case, luckily, we could achieve comfort as a sedation level of -1. So the patient was drowsy, but she was comfortable, and she was so happy. She had 5 more days without pain, able to communicate actually, and reconcile with family members. She enjoyed visits from friends, family, and especially her granddaughter, and she passed away peacefully, knowing that support was provided for her young granddaughter, who she was the guardian for. This patient ended up dying in hospital, which is not uncommon since the majority of deaths occur in hospital settings. But if a patient is stable enough to be discharged from acute care, what are your options and what resources are available? Basically, you have three options. You can send the patient home with supports. You can apply for hospice, or you can refer a patient to the palliative care unit at St. Peter's or the complex care end-of-life stream at St. Joe's. In any case, if goals of care is DNR, please make sure the patients have a DNR-C form when transferred. This form exempts paramedics from providing unwanted resuscitation measures in case the patient declines or should pass on transport. So let's say you and your patient have decided that home is the destination for discharge. You should seek for help from home and community care services. They will be able to arrange for palliative care nursing, PSW, and home equipment if needed. They will also be able to help registering a patient with the 3PC program. 3PC stands for Paramedics Providing Palliative Care. The program allows paramedics with some additional training to treat palliative care patients at a home rather than driving them straight to emerge. In Hamilton, the program was launched in April of 2021. And once a DNR is in place and a referral is made to the 3PC program, 911 calls from patients' numbers are flagged as palliative. This program aims to allow patients to remain in their homes as paramedics provide the care and medication to keep them comfortable. If you feel that home oxygen would also contribute to your patient's comfort, you have to send a prescription to a home oxygen company. If you check the box palliative under the diagnosis, there is no need to provide blood gas or proof of low oxygen saturation in order for the oxygen to be delivered, but you have to be aware this only is valid for 3 months. Another great resource here in Hamilton is the Palliative Care Outreach Team, or PCOT team. It's a team of interprofessionals specialized in palliative care, and they are a consultation service in the community. They do service all of Hamilton, and they do see patients not only in their homes, but also in shelters, in long-term care facilities, in retirement homes and hospices. A few numbers, they get 50 to 70 referrals a month, and at any given time, they have 200 to 300 active clients. The majority of patients are cancer patients, but they are open for referrals for non-malignant diseases. The requirements are you have to live in Hamilton, you have to have a life-limiting progressive illness, plus, and that's very important, the family doctor needs to be on board. The importance of the family physician's involvement is also evident when you look at the palliative care outreach team's referral form. It can be found easily when you Google Hamilton PCOT referral form. And if you zoom into the upper half of the form, you can find here that you have to check if the MRP is aware of the request and if the MRP consents. And both of these questions have to be answered with yes in order to be accepted by the palliative care outreach team. This is because the PCOT team is a consultative team. They do shared care, and they do strongly believe in capacity building for their colleagues. When you zoom into the lower part of this referral form, you will find the palliative performance scale, and you should state what's the PPS score of your patient. The palliative performance scale builds on the Karnofsky index, but includes additional categories important towards end of life, like intake, level of consciousness, and ability to self-care. 100% meaning fully active, 0% meaning death, and 30% and below is bedbound. For the palliative care outreach team, you do not need to score a specific percentage to qualify for a referral. It's more a communication tool to get an idea of how the patient is doing overall. Despite all those home care supports, some patients cannot be discharged home for whatever reasons. It might be the living situation, limited personal support, or patient preference. So you should consider application for a hospice bed. What is a hospice? A hospice, as we refer to it nowadays, is a place where care and comfort is provided to the terminally ill patients in an environment that feels more like home. In Hamilton, we have 3 hospices. All 3 hospices have all private rooms. They are run by a mix of paid staff and many volunteers. The volunteers are actually the heart of a hospice. They do welcome visitors, they cook, they serve meals, they do laundry, they do gardening, they do friendly visits. They make the hospice, like the hospice is, a very nice and friendly place. There's 24/7 nursing service. The MRP model can vary. In most cases, the family doctor stays MRP, but sometimes it's different. Hospices are free for patients and families. It's funded partly through the Ministry of Health, like 60% of the operational expenses are covered. A significant part, though, is covered through community fundraising. And to give you an idea, to run a 10-bed hospice, the donations to cover the missing 40% of operational expenses need to be approximately $500,000 or $520,000 a year. So you need a community with committed donors and fundraisers to achieve this goal. That's why hospices have a mandate to serve their community. I would like to give you a brief, first of all, the admission criteria. A DNR needs to be in place. The prognosis should be less than 3 months. The referral should come from social work if the referral is from hospital, or from the case manager if it's from an outpatient. The care needs cannot be met at home, and most often the PPS should be less than 30%. It makes things easier, but this is not a real requirement. We know there are illnesses like pancreatic cancer. Patients can walk they can be ambulatory like a few days before they die. So if you have a patient you feel meets the criteria of a prognosis less than 3 months, but the PPS might be 50 or 60%, it's worth reaching out to the hospice directly to talk to them and to advocate for your patient. Now I would like to give you a brief tour on our hospices here in Hamilton, as well as St. Peter's Palliative Care Unit, so you are prepared when a patient or their family asks you where the place is, how it looks like, and what to expect. Let's start with Bob Camp Hospice. This is the first hospice here in Hamilton. About 30 years ago, in the 90s, Dr. Bob Camp, a family doctor in Stony Creek, realized the need for hospice palliative care in the community and was determined to offer enhanced end-of-life support to his own patients and their families. He even donated his own property in Stony Creek, so the community hospice services had a home. After many years of fundraising and thanks to generous donations, the residential hospice we know now was built on the Hamilton Mountain. It's located on Stone Church Road, and it opened in 2007. Like all the hospices in Hamilton, it has 10 beds with all private rooms. Bob Camp is quite popular because they run many outpatient programs, they have grief support services, and they do several large fundraising events throughout the year. The palliative care physicians, they do have palliative care physicians at Bob Camp Hospice. So they offer the family doc to choose if they want to stay involved end of life or if their palliative care docs should take over care. It's the only the only hospice in Hamilton that allows maid provision in their place. And very exciting, they are planning to open a kids hospice in the near future. It will be the first children hospice here in this area. You can see here on the left lower corner of the picture, this is how one of their rooms, patient room, looks like. It looks a bit different than a hospital room, and all the rooms, they have a couch for family members to sleep on, and they have a window with bird feeders outside the window, so the attention to detail is evident in all 3 hospices. Next, we go to Emmanuel House. Emmanuel House Hospice is the downtown hospice here in Hamilton. The house does not really look like a hospice. You probably wouldn't expect it to be a hospice. That's because it was not built as a hospice. It was built in 1862 and used to be home to one of the wealthiest families in Hamilton. In the 1990s, it was acquired by the Brothers of Good Shepherd. They converted it to a 10-bed supportive housing residence, mainly for individuals living with HIV or AIDS. With improvement of the antiviral therapy, the need for residential care for HIV or AIDS patients decreased, and Good Shepherds developed a community residential hospice for the city. Good Shepherd is a Catholic religious order with the mission to provide hospitality to everyone, especially homeless, poor, and disadvantaged. They run several shelters, food banks, and affordable housing. And I was surprised, but I think it's not surprising to have this background now, that they even have a chapel in the place, and they have a lovely water fountain at the entrance. And I love the backyard. The backyard they have reminds me of the German beer gardens. It's very nice. So the newest addition to the hospices here in Hamilton is Margaret's Place. Margaret's Place is a hospice at St. Joe's Villa in Dundas, and it's part of St. Joe's Healthcare. It opened in 2021. 13 million were donated by the community, and it's named after Margaret Czerwinski. Margaret's Place has 8 residential beds and 2 respite beds. You can book those respite beds for 2 to 14 days to give caregivers the opportunity to bring their loved one there and care for themselves during that time. All rooms have access to private outdoor space and nature. Volunteers prepare meal, do gardening, and engage with patients and families. And as you can see here, it's very nice. It's very pretty. And when you go in there, it's such a peaceful atmosphere. So even though hospices are a place nobody wants to be, in the end, people and families are really grateful and happy there. Last but not least, I also want to give you an idea of the palliative care unit at St. Peter. It's located actually just down the escarpment, right below the Czerwinski Hospital. So if you're outside of St. Peter and you look up the escarpment, you can see the Czerwinski Hospital up there. It's a large palliative care unit. It's located on the 3rd floor of the building, and it has 60 beds. 25% of the beds are in private rooms. 25% are in ward rooms, like 4 people in one room. And half of the beds are in semi-private rooms. Like the hospices, they do have designated family rooms with kitchen and other multi-purpose rooms. The admission criteria are very similar to the ones in the hospice. So what's the difference? The difference is that the palliative care unit is part of a hospital. There is a multidisciplinary team on site, and the complexity of care can be higher. They can accommodate patients with several drains, pigtail for pleural effusions, for example. They accept patients with slightly different goals of care, still focused on comfort, but they can offer more invasive treatment. A few take-home points. Even so, palliative care used to be end-of-life care. It's not just end-of-life care anymore. When you look at palliative medicine as a discipline, there are constantly new developments. But what has not changed, and hopefully will never change, is that palliative care is a patient-centered, individualized care. You have to get to know your patient to identify and address their needs. There are a variety of palliative care resources with dedicated staff and volunteers in the community. And I do want to point out that providing palliative care is a privilege. You are being invited to be part of a patient's and family's journey at a very vulnerable time in their life. A time the family will always remember. So little things do matter. Just sit down if possible, listen, be open-minded, and do care. And even so, we do have palliative care specialists here. I'm sure everyone can provide someone with a warm blanket. I want to express my heartfelt thank you. Palliative medicine is a team approach, and you need the team to treat the patient, but you also need the team to debrief on your daily work and to give you a feeling of belonging in order to stay grounded and make your work sustainable. I want to thank you, the colleagues in the community who provided me with valuable information, not only for this presentation, but also for future collaborations. And thanks for the opportunity to talk, and thanks for everyone who shared 1 hour of the busy workday to listen in. Thank you. I'm happy to take any questions.
Thank you so much, Dr. Berg, for this amazing overview. Lots and lots to learn and ponder about, because of this important field. I see the hearts coming up, and I see the, applause coming up, so thank you so much. I'm sure many of us have enjoyed this talk, sorry. So for those who wants to get into the conversation and ask questions, please raise your hand. I'll bring you in to ask your question in person. Otherwise, please put your question in the Q&A, and I will ask Dr. Berg to respond. So I have a couple of questions. So I see Dr. Carnot raised his hand. So actually, I'm going to bring him in because he has a couple of questions. He can ask them in person. Fantastic. All right. Greg, you can go ahead.
Oh, thank you so much. I really enjoyed your talk. Can you hear me okay?
Yes, I can. Thank you.
So I just heard today that 25% of patients don't have access to a family doctor in this area. And a lot of patients never make it to hospital, and they want to die at home, and they want to get supports. And you mentioned that the family doctor is key, and I understand that. But how do we help those patients that need help and don't have family doctors, number one? An interesting problem is congestive heart failure. They can be almost dead one day and bounce back the next day, and palliative care becomes involved. But then they get sick again, and how to get rapid access and things. So I'm wondering if you give some clinical pearls in that. And thank you for all your hard work.
Thank you. So even though all the hospices, for example, they really encourage the MRP and the family doctor to stay engaged, but they also have their contingency plan in case someone does not have a family doctor. So even if you should not have a family doctor, you might qualify for hospice care. And with the heart failure, yes, it is true that the nice thing about malignancies is they are very predictable in their trajectory. With the heart failure, we have those up and downs, but we know overall it's a downtrend, even though they recover for a short period of time. So I think there is some role in exploring those patients' goals of care as well, without scaring them.
And so if I got this right, if they don't have a family doctor, we can complete the form and palliative care team will assess the patients or not?
Well, the hospices for sure do.
And no, but we're talking about the patients who are like more at home, and they're not ready for hospice care, but they
want to stay as a palliative care outreach team. So I know they really want to inform. I honestly, I just do not have the perfect answer for you. To my knowledge, the palliative care outreach team needs a family doctor, and I totally see that. But I know they also have, we also have family docs on the team who make exceptions and take on a patient as their own, but this is not the rule, for sure not. But in extreme cases, but that's not a forever solution. But we all try to find solutions for our patients and come up with a plan to try to serve them best.
Thank you so much.
You're welcome.
Thank you, Dr. Berg. There's a question from Dr. Levine related to palliative sedation, that it's only in the last 1 week of life. And what about those who are having non-remedial symptoms the last 3 to 4 weeks of life when MAID is not available to them as well?
Like, as I pointed out, palliative sedation is a tool that is not meant to hasten death. What we sometimes do if someone is in significant pain over the last 3 or 4 weeks of life, we start a kind of a sedation therapy and we sedate the patient, but we also do that intermittently. So the patient can wake up in between, can eat to the family, can speak to family, and might have some sips of water or things like that. So that's as I said, it's a very individualized approach to patient care, and we always have to keep the patient in mind.
Thank you so much. There's a couple of comments. Just want to make sure that everyone get access to them from our other palliative care colleagues. It is that the teaching practice services can take them on, and they can help with palliative care, finding a family doc for them as well. Those are in the comments. And I'm assuming that, you know, a specialist could take the responsibility of MRP to Dr. Carnou's question.
Yes.
If willing to receive the calls and help with prescriptions and other things, right? So
most definitely.
I just want to make sure that any of us could be potentially the MRP on the cases if you wish to do so.
Thank you for pointing that out.
And there's another question in the chat. Could you provide a couple of specific instances, perhaps some scope related, where a family physician would reasonably choose to consult the PCOT team? So that's not really from hospital, I'm assuming, but from the community.
I talked to the PCOT team, and I feel they are very approachable. So I feel whenever a family physician feels they could benefit from some palliative care experience, some palliative care input, they can reach out. It can for sure be the patient with, as I said, most referrals are cancer patients, but even though patients with end-stage renal disease, end-stage lung disease, they all can be referred and to the PCOT team, and they will decide. But even if they do not take a case, they might be able to talk to you and to give some advice.
Fantastic. Thank you very much. I think we're almost at time. I just want to highlight that most recently I was exposed to what's called the bow tie model of palliative care, where start when a chronic disease is diagnosed and it builds up, you know, until the end of life, which I think, you know, something, you know, being a general internist myself and many of my colleagues in their subspecialties in general internal medicine know that, you know, we at the end of life, you know, we don't know what to do, and we struggle to bring in or should I scramble to bring in palliative care involvement, where we should be doing that early on. And just want to reassure everyone that currently we work very closely within the Department of Medicine at Hamilton Health Sciences with the palliative consult service, the outreach program, and we're building with our current leadership and our colleagues like Dr. Berg and others a new approach, hopefully in the next few years, for palliative care that is deserving for our patients, similar to what Dr. Berg's been describing today. So we're getting there. It's going to take some time and effort from everyone. And just want to make sure I'm not missing anything. Just great comments from everyone, Dr. Deborah Koch and others, about how fantastic is this talk. So thank you very much, Dr. Berg. I would we'll stop here since we are at time, and thank you again for this fascinating talk, a very important topic that involves everyone. And I love saying again, you know, palliative care is everyone's business. And I think we have to remember that every time in our practice. And thank you very much. Thank you for your colleagues who contribute also to the comments. And I wish everyone a great rest of the day. Thank you.
Thank you very much.